Next.
Next, can we have Dr. Vishnu? Clinical features, diagnostic challenges and multimodal imaging in pre-papillary vascular loops.
कहाँ पर है? इसमें कहाँ है?
विष्णु ये सेकंड वाला है.
सेकंड. अच्छा, ठीक है. इस प्रेजेंटेशन. हाँ.
Good morning, good afternoon. Before I start, I would like to thank the AIOS team and my teachers from Aravind Eye Care Hospital for giving me this opportunity. So I'll be talking on, just a minute, sorry, this is not the presentation.
दूसरी है, second.
Yeah. I'm sorry for the delay. I'll be talking on clinical features, diagnostic challenges, and multimodal imaging in pre-papillary vascular loops. Case number 1, we had a 50-year-old male referred from general OPD for query neovascularization of the disc. He had no systemic comorbidities. His best-corrected visual acuity was 6, 6, and 6 in both the eyes. Anterior segment examination was unremarkable other than the presence of early cataract. So right eye fundus examination was normal. Left eye showed, I'll just zoom in the fundus picture. Left eye showed a single division of the artery with multiple loops superior to the disc. There were no signs of NVE in the periphery. There were no breaks or tears. This is the OCT of the same patient showing the position of the loops, which is located in the innermost area near the RNFL and vitreoretinal interface. FFI was done for this patient and it was quite unremarkable. There were no late phases of leakage or staining seen. So case number 2, we had a 22-year-old male referred from general OPD for floaters for the past 3 to 4 months. He had no systemic comorbidities. His best corrected visual acuity was 6, 6, and 6 in both the eyes. Anterior segment was unremarkable in both the eyes. Fundus of the examination of the right eye was normal. I'll be zooming the fundus picture of the left eye, where we see the inferior division of the artery showing multiple loops with no shunting across the nearby vessels. FFA, before going to the FFA, this is the OCT of the same patient showing the presence of vitreous hemorrhage and the more inner location of the loops with near the vitreoretinal interface. FFA done showed no significant leakage, but there was mild staining in the late phase. Case 3, we had a 47-year-old female who was diabetic for the past 15 years. Best corrected visual acuity in right eye was 624 and left eye was 6998. Anterior segment examination was unremarkable. Right eye fundus was post-vitrectomized eye for tractional retinal detachment due to diabetic retinopathy, and left eye was status post PRP. Here we can see arterial loop, single vessel arterial loop with no shunting seen projecting into the vitreous. This is again the video of the same patient showing a pulsatile arterial loop. Okay, next we go into the OCT. OCT done over the loop showed a central lumen with projection into the vitreous. So our clinical diagnosis, pre-papillary vascular loops. Our DDs were optociliary collateral veins and retinal arterial velar anastomosis and cilioptic vein and acquired loop following CRA occlusion. Congenital retinal vascular anomalies include the following: anomalous macrovessel, arterial crossings, venous crossings, triple branching, congenital tortuosity, and PVLs. PVLs were described as a congenital vascular anomaly. It initially misdiagnosed as a variant of hyaloid vessels, but recent histopath and FFA shows they are either a branch from retinal artery or vein ending at the disc. They can also project some distance into the vitreous. Coming into the pathogenesis, we all know that retina is supplied by hyaloid artery up to the 4th gestation month. At 4th month, primitive vascular mesenchymal cells near hyaloid artery invade the RNFL, forming retinal arterial system. During this formation, when the primitive mesenchymal cells deviate from their normal path, we get the PVLs. Mansur et al. In their multicentric collaborative retrospective study classified PVLs into 6 types. The first one is a flat intraretinal loop with no associated retinal vascular anomalies. The second one is flat intraretinal loop over the disc with retinal arterial or vein anomalies as seen in our case 1 and 2. The third one is a figure of 8, a small Chinese letter pattern loop, which is most commonly seen in Asians. The fourth one is a figure of 8 loop. The fifth one is a corkscrew type, and the sixth one is any loop with vitreopapillary traction. This is the proposed classification by Mansoor et al. Tortuous OCT patients, they can have either tortuous, hairpin, or loop, or spiral. Somia et al. Published a case where they had a B scan with, where they had a VH with brown cataract. B scan showed again VH. While doing PPV with phaco, vitreous massive bleed from the stump of disc was noted, and after 1 week, vitreous lavage was done. Fundus showed vascular loop projecting into the vitreous cavity, which was confirmed by the OCT. A retrospective analysis by Shinji showed a prevalence of PVLs to be 0.115%. Complications, they are mostly asymptomatic, but they can cause some bleeds. To conclude, PVLs is a vascular anomaly around optic disc, and they are mostly asymptomatic and requires no intervention. Multimodal imaging plays a vital role in diagnosis and doing unnecessary investigations. Thank you.
So what is the clinical importance of your presentation?
So to prevent doing unnecessary investigations and identifying this condition as a rare entity, we can come to a conclusion that such patients...
but you did a lot of investigations. You did FFA, you did OCT.
So after the second...
Is that what we should be doing for every patient who
No,
comes?
ma'am. After the second case, when we diagnosed that post-PRP case, we came to know, we recognized this entity, and this patient was not subject to...
So for the post-PRP case, did she actually require PRP? Did she have NVEs elsewhere, or was that loop misdiagnosed as an NVD and she underwent?
It was misdiagnosed as an NVD, and we followed the case for 6 months, and we recognized that as a clinical
But she
entity.
had a TRD in the other eye.
Other eye, yes, ma'am.
So that's actually a case where an angiogram is required for this eye to note whether it is or not. But in the other cases, clinical signs which you should have emphasized to distinguish between the two.
Yes.
Thank you.
Thank you.
Next.